Thank you very much for the opportunity to present in this New Horizons session. I like to think of myself as the hype man before Debbie, who's going to be talking about elimination tomorrow. Just to set the stage, and I think this is true of my other fellow speakers, these are kind of the what ifs, the what's next. So what I'm presenting to you are sort of ideas or places that we could go, but I think as roundtables, we need to define for ourselves what we mean or what we think about when we're saying the word elimination or elimination of HPV-related cancer, starting with cervical cancer. So many of you are aware that in November 2020, there was a pretty big moment in history where the world committed to eliminating cervical cancer. The impetus for this was actually in 2018 when the World Health Organization Director General issued a call to action to scale up prevention, detection, and treatment, and called on the world to finally eliminate cervical cancer as a public health problem. And that sounds very familiar to the conversations that we're having today. So what I like is that in 2020, the member states of the World Health Organization stepped up and said, call accepted. They issued a resolution, which is called WHA 73.2, and they adopted a global strategy to accelerate the elimination of cervical cancer. And we heard a lot about data. One of my favorite things is that they actually set priorities and targets to be able to achieve this lofty goal of elimination of HPV-related cancer, starting with cervical cancer. So it wasn't a surprise that the world stage stepped up when we really think about what the global impact is of cervical cancer. It's the fourth most commonly diagnosed cancer worldwide, over 500,000 women. So when we think about, there are thousands of women, but we're talking in the US, 500,000 women in the world, over 500,000, are diagnosed with cervical cancer, and more than 250,000 women die of cervical cancer each year. And this number feels wholly unacceptable when we think about the fact that we have the tools today to be able to prevent this cancer from ever occurring in the first place, and certainly to detect it at a much earlier stage, even before cancer takes hold. So the global targets set by the World Health Organization, I often think of them as 90-70-90. It's a really easy way to think about what we're striving for on an international stage. So that is that 90% of all girls are fully vaccinated with the HPV vaccine by the age of 15. 70% of women are screened using a high performance test, similar to characteristics of HPV DNA testing, for example, at least by the age of 35, and then again at age 45, and that 90% of the women with precancer are actually treated, and 90% of those that have invasive cervical cancer are appropriately managed. Now, while the US doesn't have exactly these targets, we do have some targets that approximate what the world is trying to do with regard to cervical cancer. Many of us are familiar with the Healthy People 2030 objectives. So we know that one of those is to increase the proportion of females ages 21 to 65 that get appropriate screening for cervical cancer. You can see what the target is and where we are as of 2021. This is based on National Health Interview Survey data. Another example of a target that gets us closer to elimination is increasing the proportion of adolescents who get all the recommended doses of HPV vaccine. You can see we're a little bit further off on this one. Our goal is 80%, but as of 2021, we're at 58.5%. I know some of you have probably seen the most recent NIS teen data that came out that actually showed for the first time we haven't seen an increase in HPV vaccination in the United States, and we look specifically at kids that were insured by Medicaid, we saw a decrease in the vaccination rate. So this is something that's particularly relevant and important. And then another is to reduce the types of HPV infections that would be covered by HPV vaccine in young adults. This is based on NHANES data that's collected on a routine basis. So we've got some targets, but we also have a ways to go. But I also want to have us thinking forward and what is positive, and that is that cervical cancer elimination in the US is within sight. The definition that generally is used by the World Health Organization and others when we say eliminate cervical cancer is less than 4 cases per 100,000. So what we see from this SEER data is that cervical cancer rates have steadily been decreasing over time. We see that there is some narrowing of disparities, for example, with the blue line of Black or African American individuals that are diagnosed with cervical cancer, sort of coming closer to the white population or all races. And I apologize, I should have more of the other racial ethnic groups so you can see that, you know, there's definitely, we talked all day today about health equity. So when we think about a strategy, there's some groups that are going to need different approaches, more intensive resources than others if we're to collectively achieve that elimination goal. This was another, what's the right word? Motivating paper that I came across. This was published in Lancet Public Health in 2020. And it was an interesting paper that looked at actually about 9 different scenarios and used mathematical modeling to see, okay, we talk about elimination all the time, but what does it really look like in terms of being able to achieve elimination? So scenario 1 was the status quo. And what they meant by the status quo in that paper was they used NIS teen data to sort of see, well, what's the steady increase or increased rates of vaccination? And they modeled what if every 12-year-old female in 2020 received all recommended doses of vaccination by the time they turned 17, and every 12-year-old male in 2020 if 55% of those individuals received vaccination by the time they were 17. And they used data from the New Mexico PAP and HPV registry to also approximate what if we kind of continued along in terms of the proportion of women who are eligible that participate in screening. So about 85% of women participate in screening, and then the subsequent follow-up for abnormal results, treatment, and then for those diagnosed with cancer, treatment. And so that's the status quo, like if we use the data from today to see what happened. Then they used another model where they said, okay, what if we upped the vaccination rates for that adolescent age group to 90%? Would that get us to elimination faster? And that's what we see as scenario 3. What you see is actually both scenario 1, the status quo, and scenario 3 get us to elimination around the same time. So as long as we keep continuing to push vaccination at the rate that we are, and we continue to achieve these high rates, which I just told you were kind of falling off a little bit, we'll probably wind up with an elimination goal that less than 4 per 100,000 in 2038. So I did a little bit of math. By then I would be 64, perfect. Time for me to retire, job done. Okay, I can move on. So that's great. But they tried another scenario where instead of increasing the vaccination rate, they said, what if we improve screening? Cervical cancer screening, follow-up, and treatment up to 90%. What would that look like? And what you can see, that's scenario 2, is that we'd be able to achieve elimination 10 years earlier, and 2028 doesn't sound that far away. So again, these are mathematical models. There's a lot of assumptions that go into this, but it gives us an idea that, of what I believe, which is that we're sister roundtables. We need the HPV vaccination and we need the cervical cancer screening. And together, I don't know how many of you know Wonder Twins Unite, but that's what I feel like we could potentially do. The other bonus of scenario 2, as they mapped it out over time, is that we could potentially, by 2063, get to less than 1 case of cervical cancer per 100,000. So again, in our lifetime, in our children's lifetime, we have the potential to eliminate a cancer that causes such a burden in our society and really disproportionately affects segments of our population that we all want to do more and better for. Another thing that I think the World Health Organization did, which should save us all some time, is we've heard a lot today and yesterday in our steering committee meeting about initiatives, things that we'd like to do, what would we like to focus on. But what the World Health Organization did was they created a really nice implementation and evaluation framework that thought about all of the potential strategies that we could do as falling into 3 buckets, which is primary prevention, right? That's where our HPV vaccine roundtable comes in. Secondary prevention, so that's where our cervical cancer screening roundtable comes in, as well as our focus on tertiary prevention. That is, Dr. Castle felt the need to go over time and say we need to think about cancer survivors and how important that group is, that we consider all of these. But what I like is that they gave us some metrics to start thinking about so that when we as a group are starting to think about, well, what should we do? Our next natural question is, how do we know whether it made a difference? And so with with this particular framework, I think we'd have the potential to plug our initiatives into these different areas to make sure that what we're doing is actually making a difference. And it might be something that we could potentially adapt for our groups. So I think, you all probably agree with me that we have all the tools today that we need to eliminate cervical cancer. HPV vaccine, screening, and treatment. And if we do these in a timely way, then we have the potential to eliminate a cancer in our lifetimes. But I want to go back to something that I've heard kind of throughout the day, which is this idea of unity of effort. And we have some of the best and brightest minds that are sitting here in this audience that understand communities, that understand data, that understand clinical care, that understand how to engage with diverse populations. And if we all collectively think about a common goal, I think we can do so much. So I'm going to leave you with this thought, which is the world has stepped up. They've accepted the challenge. They're ready to eliminate cervical cancer. And so I leave us with the question of, are we ready to eliminate cervical cancer? Thank you.
It's always fun following my friend Susan. I, for one, am inspired. So my name's Francisco Garcia. I'm a recovering pointy-headed academic who spent way too many years of my life writing peer-reviewed papers and doing PowerPoint presentations. And I've transitioned to a different role, which is really thinking about the health of populations. And in my current role, I get to think the big thoughts about a geography that's the size of the state of New Hampshire, that has 1.1 million population, that has 2 large sovereign tribal communities. Oh, and by the way, that shares the largest international boundary with Mexico of any county. So that is the context, and context matters, and that will be kind of the recurrent theme. My goal is to be a little bit provocative and to think about how context presents both an opportunity and a challenge as we think about implementing self-collection. I was looking at my old CV, and my first self-collection paper was published in the Green Journal in around 2005. It was a comparison in the clinical setting of women self-collecting a specimen. By the way, we also ran cytology on it. And at the time, it was just a feasibility trial. It was something that we were just sort of playing with. But it was remarkable in that it was a team of two, I never anticipated the degree of uptake and acceptability, honestly, that we would have from patients. And the reason I didn't anticipate that acceptability was because there were a lot of predetermined biases that said, oh, Hispanic women don't want to touch their genitals, and if you go, because we did this in Mexico, we did this in a border community in Arizona, and we did this in Peru. And if you give women the opportunity to do this, they're not going to want to take part in it. And that was one of the most important lessons that I've learned throughout my career is that women will always get to the right answer. People will always get to the right answer, and that we need to be more open-minded. My goal is just to help you envision what the impact of self-collection for primary HPV screening could be as a strategy for cervical cancer elimination. This is still kind of an evolving field, but I think we also have an unprecedented opportunity to think about how all these things can come together. And Susan talked about the 3 different elements that lead us toward elimination, and thinking about how all of those work with each other. And in particularly, how self-sampling becomes kind of an important tool as we address some of the critical gaps in disparities. This is a graphic that I've used forever that talks about what I believe a comprehensive cervical cancer prevention strategy involves, and it has all these different elements, which today we have the luxury of being able to draw from. We have all the tools in the toolbox. The question is, are we applying the tools to the right populations? The question is, are the populations that are receiving the tools, are they benefiting from our interventions? And I think that that's where the jury can still be out, right? We pretend that this is an integrated system, but it is not. And indeed, when we think about the way we deliver healthcare services in this country, and in most countries, honestly, it is a fragmented non-system with a lot of different actors. And at each one of those intervention points, is owned by a different actor, and at each one of those intervention points, there's an opportunity for leakage, for people to fall through the cracks. And I think that that is one of the pieces that I want to sort of leave with you. So I talk about why is it that the burden of cervical cancer morbidity and mortality is, and why is it that low income and communities of color are disproportionately impacted? It's all about context again. It's not that the biology is fundamentally any different. We know it's high-risk type and persistence that are the things that determine whether a woman develops a pre-neoplasia of the cervix. But there are all these other contextual factors that are around her life that impact her ability to access those services. Those contextual factors are real, and those contextual factors play themselves out in very unique ways. In Arizona, in the border country, it may be about geography, right? It may be about the fact that if you have to go from Ajo to the city of Tucson for colposcopy, you're in for a 2-hour drive in a car. And you can imagine that that may not be so easy for someone who has to pass through 2 Border Patrol checkpoints. It may be about service availability and immigration status, and all the other kinds of systemic obstacles that in and of themselves become barriers and become challenges for individuals who are trying to access services. Health literacy is something that we talk a lot about, but that I think that is still very much in its infancy in terms of how we implement this in population settings, where the strategies really are about social marketing and large media campaigns, and where they are less targeted to the individual needs of folks. And fundamentally poverty and lack of access to services. Part of what I do among the other units that I oversee are the departments that deliver eviction prevention assistance, the departments that deliver early childhood education. These things are big needs that our communities, that our poor communities have, that our poor communities of color have, that is the context in which primary prevention and secondary prevention is played out. One of the pieces, and I think it's a recognition of that fact that context matters, that I'm really proud of the fact that ACS has centered equity as such an important foundational element as it helps us move towards a national elimination strategy. It is precisely because these contextual factors are going to impact whether people can access those services that it actually matters. And only when we do that are we able to bring the end user, the client, the woman, the person with the cervix into the conversation. One of the roles that I played was overseeing our COVID response for this jurisdiction. And one of the things that I believe is that if we do not learn the lessons of the pandemic, that we are going to miss a really important opportunity. If we think back to March of 2020, if we think about how the world changed in those subsequent 6 months, and we think about how healthcare services and healthcare delivery was transformed during that period of time, I think that there are some important lessons to be learned that are applicable directly and uniquely to self-sampling, self-collection for primary HPV screening. Think about the fact that heretofore, on demand, free to consumer, no appointment necessary, testing being delivered in community settings was the rare exception rather than the rule. I can tell you that in the county of Pima, we administered several million tests, almost all of them in community and field settings. And in those field settings, we were able to reach populations uniquely that needed those. We were able to tailor our approach to specific census tracts. We knew where disease was happening. We knew where we needed to deploy people and resources, both testing, vaccination, even therapeutics. Again, at-home testing became something that was not only being encouraged, but was being covered for by the federal government. Non-clinical settings ended up being the major source of delivery of these services. And what I thought was pretty phenomenal was a fairly rapid dissemination of this rapidly evolving technology. With all its pluses and minuses and all the mistakes that we made, and we made some along the way, I still think that it was a remarkable response, and it was a remarkable impact that we were able to have. Certainly in our county, we're able to achieve 80+% vaccine coverage, and in other settings. So where and when do we think about deploying self-collection? So again, thinking of it from the context of the border, thinking of it from the context of poor communities, these are the kinds of settings where I really see the possibility really opening it up. And this is not original to me. This is what has been done by colleagues across the world and across our own country, innovating in this space with the idea of moving forward. But the big thing that I will tell you is that we need to make sure that if we employ a self-collection framework for primary HPV screening, that we not ghettoize this. Because if we do, if we make this the thing that poor women do, the thing that brown women do, we will have lost an opportunity. We'll have lost an opportunity, and we will not get the kind of uptake that is absolutely essential in order to be able to make this a feasible technique. So I think we can get to there from here. I don't think it's a perfect system, but in that imperfect non-system, self-collection ends up being, I think, a cornerstone element that I hope that we can build upon. Thank you so much.
Hi, everyone. Aimée Kreimer. I am with the U.S. National Cancer Institute, and I was asked to speak today about one dose. So what do we mean when we say one dose? We're talking about the number of doses that women or even men need to have adequate protection. And so I wanted to start just with a little bit of a story before I jump into data, and I do have a lot of data because when we're talking about reducing the number of doses needed, this is very much an evidence-based decision process. I want to be clear about that. So how did we get to 3 doses to 2 doses and now to 1 dose? So as everyone knows, these HPV vaccines were proven to be safe and efficacious 17 years ago. And when the pharmaceutical companies ran the trials, they ran it with 3 doses. That's vaccine dogma. You have to prime the people, you have to prime them again, and then you boost. And then we get the big antibodies, we get the protection. So the HPV vaccines kind of exceeded all of our expectations. They were incredibly protective, approaching 100%. And so that started to raise questions. Well, maybe we don't need 3 doses. And so studies were launched to say maybe 2 doses is enough. And these studies were done in in adolescents, boys and girls. And so what they showed is that the antibody levels that were induced by 2 doses in adolescents were the same as 3 doses in these women, which was our efficacy population. And so that's how we moved to 2 doses in adolescents. Did we observe that 2 doses, that you need that 3rd dose in the women? No. It's just the way the studies were run. So even though I'm talking about 1 dose, I did just kind of want to flag for you that I think in the next few years, we're actually going to see a lot of movement in how we recommend these HPV vaccines. So I'm going to talk about the state of the evidence for single-dose HPV vaccination. And I'm actually going to launch right into a series of studies that I would like you to have, and then I'm going to talk about the future directions. So there's really been, I'm going to actually do a little more storytelling. Hold off on that. So when these trials were launching, run by the pharmaceutical companies, our government said, you know what, we want to be able to also independently investigate this. So they launched a trial in Costa Rica with 3 doses prior to licensure. And with that, they said, you know what, 3 doses does work. But because this was in a community setting, they also had women who had just received 2 doses and even women who received 1 dose. And so with that, we were able to look at the protection afforded in each of these groups. The pharmaceutical companies didn't do that because I think they want to give more doses to people, but I could be wrong about that. So we did look at that, and that's where we kind of launched this idea that, you know what, maybe you don't need 3, maybe you need 2, maybe you need 1. And a whole suite of studies has been kicked off. Why is 1 dose important? I look at it from 2 perspectives. One, we've talked about uptake here so much. If you only need to give one dose, we don't need to look at completion of doses. It's just the one dose. That's easier. That's cheaper. People, my kids don't want to get multiple doses. Like, it's just a win if the protection is there. And the protection maybe doesn't need to be perfectly there because vaccines do two things. They do the direct protection to the person who gets vaccinated, but they also get the indirect protection, the herd immunity, from everyone else around you getting vaccinated. So maybe one dose is just the same as 2 or 3 doses, or maybe it's not exactly the same, but good enough. So that's what these trials are trying to understand. There was a big breakthrough that came in a trial coming out of Kenya. Results were published about a year ago. They studied the bivalent vaccine and the nonavalent vaccine. I know that in our country and globally, the nonavalent vaccine is what is used, or even the quadrivalent. That actually, I think, in my opinion, encourages unhealthy markets. We don't want domination by one pharmaceutical company. We love to have multiple people in. So from a global perspective, it's really still important to encourage multiple vaccine manufacturers. In this, I wonder if I can you see a pointer? No. Okay, so really quick, they looked at the nonavalent vaccine, they looked at the bivalent vaccine. This work was done in Kenya in girls or women aged 15 to 20, and what they showed compared to 0 doses is that the protection was almost 100%. So this was after a short amount of follow-up. We don't know how long the follow-up will go, but this is a randomized clinical trial. This is our highest form of evidence, and we see fantastic protection. There's another study that's been going on in India. This is not a study where people were randomized to one dose, so that's a bit of that holds us back from really embracing the data as much as a randomized clinical trial. But there's been a lot of work to understand, is there a selection bias? How valid are these data? And again, this is with the quadrivalent vaccine. So in India, they've showed 1 dose, 2 doses, 3 doses in girls who are vaccinated between the ages of 10 and 18. Vaccine efficacy incredibly high and similar across number of doses. In this slide, I'm showing, so I told you this, this work that we do in Costa Rica. We did this, original, we saw vaccine protection for 1, 2, and 3 doses after 4 years, 7 years, we're incrementally following them. This is our published data out to 11 years, and we actually have unpublished data to 16 years. And the reason this is important, so the first thing people said is 1 dose will never work. You have to follow this prime boost, or at least prime boost. 1 dose won't work. And then we said, hey, look at the data, it's working. And then everyone said, it's not gonna work long enough. We need durability. We have to give these, 12-year-olds or 10-year-olds or 15-year-olds, whatever we're doing, we need 2 decades of protection. And so the reason these data are important is I'm showing these antibody titers, and they're flat. They're not going down. And so this is to 11 years. The 16-year data look the same. So we're getting there. We're getting to 20 years, which is kind of like our minimum time limit that we really want to protect people. We want to cover their teens, and we want to cover their 20s. Longer is better, for sure, but at least the minimum is 20 years. And so the data are getting there as well. And I wanted to, I am going to close with some gaps in the literature, but I wanted to pull this slide up because everything that I've shown to date has been women, women, women. Why? Because when we talk about the HPV-driven cancers globally, which is my typical lens, cervical cancer dominates of all the other cancers. Of course, that's not the case in the United States. We do see this, similar rates of cervical cancer and oropharynx cancer. So that changes our perspective, of how we vaccinate, and we think about boys too. So what we're looking at in this slide is a study that was done in the United States that actually did include boys. And basically the gist of the study is that it shows that the response in boys to 1 dose is really the same as the response to girls in 1 dose. So this isn't conclusive data, but it kind of keeps advancing the hypothesis. 1 dose will work in the short term. It works in girls. It works in the longer term. Now it works in boys. And then there was a study that came out of South Africa that I wanted to flag, because another big question is, what about people with HIV? And so this study that came out of South Africa showed really some promise that people with HIV will be able to mount an adequate immune response to one dose. I will say, we don't anticipate ever saying people with HIV who are in a care setting should just get one dose. They will probably continue to get multiple doses, but we do wonder about, what about, for vaccinating girls, they later acquire HIV, so this sort of more informs that question. But again, more reasons for optimism. And this final slide on the science before I go global is really just reinforcing this idea that herd immunity is greater than is expected. So, in everything with one dose, I think we have to be just a little bit mindful, like, what is the goal? Is the goal that the one dose will be the same as 2 doses, as 3 doses? I don't know that it's even necessary. Susan showed, that we're really starting to control cervical cancer. We're controlling HPV prevalence. So even if one dose, and we're running studies, we'll be able to address this question directly. But even if it's not the same, it could very well be good enough. So just to kind of take this to the global level, WHO, World Health Organization, did review all of the single-dose data and put out a weekly epidemiologic record almost a year ago now, where they've now changed their recommendations. And so this is to address what the world is doing. They now allow for a 1-dose vaccine program or a 2-dose vaccine program. And that kind of 1 or 2 doses reflects that there is still ambiguity. We don't exactly know yet if 1 dose is as good as 2 doses. They set this for the primary target of girls 9 to 14, but also note they did it for young women aged 15 to 20 as well. So I think, again, I want to emphasize, so much of what you're doing is so important. You're thinking about, how do we get the second dose in? How do we maximize that? Well, I also just want to flag that maybe in a few years, as these 1-dose data come out, we're not going to be talking about completion of a series because we have to do 2 doses. Maybe the U.S. will also be given just a single dose. I wanted to flag, there's been some big progress. So, here we're talking about, how do we get vaccine uptake to 80%? There are many countries in the world that have 0 vaccination. It's not offered in part of their national program. This is more, crushing and devastating to me, because these are also some of the countries that do have the highest burden of cervical cancer. Again, Susan showed us, how close we are to elimination benchmarks, and there are countries, where 1 in 100 women get cervical cancer. And so from a global perspective, these advances are really critical to make HPV vaccines more accessible. Here's a list of some of the countries that have already taken action based on these WHO recommendations. It says, these data look strong enough. They're either bringing, they didn't have HPV vaccination and now it's in their national program. Maybe they were given 2 doses and now they're giving 1. Maybe they're giving the second, that extra, it reduces the number of doses that you need by 50%. Maybe they're giving the others to boys. Maybe they're going up in age range. It really kind of frees up resources as well. So lots of promise. I would be remiss if I didn't flag gaps in the literature. Again, we need to stay very true to where the evidence base is right now. We cannot say, it's perfect, we know everything. We are not there yet. So I had flagged this one earlier. We don't know how, if a girl is HPV vaccinated and then acquires HIV later in life, we don't know how that will impact the HPV vaccine antibodies. I think that's less of a primary concern here. When we're thinking of countries like South Africa, where the epidemiology is you get HPV vaccinated, and then, in the late teens, they're acquiring HIV, and the HIV prevalence is so high, it's really critical to know in countries like that. Again, males, we do not have a ton of data on, and in the US, we obviously do, male and female vaccination. We don't have a lot of data on adults, although those studies, stop. Okay, We don't have data on non-cervical sites, which in the United States is a priority. We don't know how one dose will protect against oral infections, anal infections. The biology and everything we know, vaccinology, immunology, it will work the same as it does in cervix. That's what we've learned to date. Studies are in flight to prove this, and of course we want to live with the evidence. I just want to tell you more data are coming. I think this will culminate around 2025, 2026, which like in research time is tomorrow. So yeah, durability to 20 years in Costa Rica, 10 years in India, Tanzania, okay, lots of places. Yeah, I think the one thing I also wanted to flag is, you know, there will be this kind of bolus of data from the types of studies that I think, you know, the United States may be poised to make decisions based on in the coming years. And then we're also running studies that go up to the age of 30, because again, if one dose works as well as 2 or 3 doses, or if one dose is good enough in the face of herd immunity, then why would we, you know, misuse resources when we can bring it down to 1 dose? So studies are coming. Here's just a flash of one of them. I'm happy to talk more. My contact information is on the bottom, and I will stop.
Jeff Andrews, doctor and medical affairs at BD. In the spirit of equity, I think the slide that you showed, Susan, that shows where we are and how we can eliminate, which said that the US was at 6.5%, and you said, oh, we're within sight of 4%. There's actually 2 different groups in the United States. So the women who are being screened are already there. They're already just below 4%. Then there's another group of women, maybe 30% of the population, that are at 13 per 100,000, which is the group that Francisco was talking about that we need to reach. So thank you.
It's really heartening to see this high quality data at the roundtable and our joint meeting with the, well, actually, I guess both roundtables. So thank you for the presentations. They were terrific. I'd like us to take some more care with how we talk about elimination as a public health problem. So we talked about it today as elimination, cervical cancer elimination, which is not a thing. It won't happen. It won't happen in our lifetime or anyone's lifetime. We can't eliminate cervical cancer with the technology we have, in part because some cervical cancers aren't caused by HPV, in part because the vaccines aren't perfect, screening isn't perfect, and so on. So even when we declare it eliminated as a public health problem, we will still have women dying from cervical cancer. And that's a challenge with our language. So we are not eliminating cervical cancer. We're eliminating cervical cancer as a public health problem. We're bringing it below a certain threshold. And so one of my roles is to certify the elimination status of the United States for measles. And so we take that very seriously. And that means no measles domestically transmitted, only imported cases. So we're never going to have that for cervical cancer. So the use of elimination language here requires more care, especially given who we are as scientists, as public health practitioners, as people affected personally or through our family members and loved ones by HPV cancers. So elimination as a public health problem or near elimination, fantastic language. And maybe we say elimination as shorthand, but when we first use that term, let's say elimination as a public health problem. Thank you.
It's such an important question. It's such an important issue that you flag. The way we use language matters, right? I think that I'm all for big, hairy, audacious goals, and I think they are inspiring. But I also worry about how we frame expectations for the public and how we use this language in a way that's more precise, so that it's meant to inspire, it's meant to move us forward, but it also acknowledges the reality. And my friend Phil Castle has been talking about that for a while.
And I'd just like to add, I think tomorrow we'll have more discussion around sort of the concept of elimination, what it means to us as a roundtable, and you're absolutely right in terms of messaging, and absolutely right, the World Health Organization talks about it as elimination of cervical cancer as a public health problem, but that may not sort of be clear or resonate with non-public health individuals.
Jeff and Noel actually hit a couple of my points, but I want to amplify to make it very clear. Jeff's point is if we reach those underserved women, we would actually achieve that 4.0, right? like today, like if we just did it. And to Noel's point, I think it's, when you start getting to the very edge of this in terms of the number, you have a real potential of harming women to get down to this zero or elimination. And keep in mind that the ACS vision statement, which could be misinterpreted, says no cancer, right? No cervical cancer. So already the language is a little bit misleading and could take you to a place that you don't actually want to go. And at that point, when you're trying to get that last 10% or whatever it is, that money could be spent on other things that the same population is experiencing. If they're experiencing cervical, an undue burden of cervical cancer, they're experiencing colorectal cancer, lung cancer, breast cancer, prostate cancer. I mean, I can show you the maps. It's the same group of people. Diabetes, cardiovascular disease. We have to think about the gestalt of the women, not just their cervix. It's important, and I've worked on this for 25 years, so I'm all on eliminating cervical cancer. The other thing, two other quick points, and I'm sorry to bogart the microphone here. The first point is the key person in the healthcare system to reach these underserved populations is the community health worker / patient navigator. It is not currently a billable service in CMS. These are the people who will interface in these underserved communities, will be the trusted source. They look like the people that we're trying to help. They speak the language of the people that they're trying to help. These are, and the evidence is overwhelming that community health workers increase uptake. And yet they're not part of the medical home because they're not paid. The second point I want to make is we have this great program called the National Breast and Cervix Early Detection Program. It provides screening, it provides diagnostic services, it needs to be expanded, and then it needs to include treatment. The fact that we can get all the way, but we don't provide, and let me just say, screening, we don't have to qualify screening anymore. We shouldn't have to qualify it as all these steps. There's testing, there's diagnosis and treatment. All three of those together equals screening. We don't have to qualify screening as having treatment. It isn't screening unless you provide that. So I'll stop there. Thank you. Sorry to get on my high horse.
Hi, thank you all. This was really excellent. I have a question about the data that you were showing on the curves on achieving elimination of cervical cancer as a public health threat. I've seen data over the last couple years around the impact of the pandemic and reductions in vaccination, reductions in screening, and that advanced cases of advanced stage cervical cancer diagnoses are on the rise. So how does that data intersect with the simulations that were shown in that study? Thank you.
Yep, that's a great question, and I'm glad you brought it up because that paper was published in 2020, which means they were using data prior. And so that's where I was saying, these are models and they're sort of using what the best estimates were at the time. So it is possible that those curves are going to shift because we know that there's been both declines in screening and vaccination rates that would, sort of push that out past my 64 years of age retirement that I was planning to. So that's a really good point. And yes, that paper was published in 2020. So they were using data prior to that.
Okay, thank you so much.
Thanks, everybody. Great talks. I had a question for Aimée. So what would you say to this? 16 years of data with looking like duration of protection is sufficient for one dose. Could we go to ACIP, sit on the work group, and if they're voted for one dose, and then if your data show that in year 18 or 20 or 22, something changes, could people then get a booster at age 30? I know there's downsides. It's harder to get a booster for somebody at 30 than at 12, but is that feasible?
So many component parts to that. So first of all, If it stays flat to 20 years, from what we understand in vaccines in general, like the shape of the wane matters, and if it wanes, usually it's a little, it's not just, it doesn't fall off the cliff. And so, if it's really stable out to 20 years, the like long-lived plasma cells are not going to just stop. So I think once you document, and this is beyond my expertise, but when I talk to, the immunologist, or, it really actually is the indicator that it's not going to stop. And so I don't know that we want to continue following this one, group of people, although again, India's doing, like lots of populations around the world are following women and who have been vaccinated with one dose into the long haul. I think then what will have to happen is we'll have to move to vaccine effectiveness studies where what we're keeping, we're monitoring that. And I didn't get a chance to say it, but that was at the bottom of one of the slides. It's just how do we monitor for failure. And in terms of boosting, it would have to be how badly does it fail? That becomes like cost benefit, I think, analyses. How poorly is it doing? How much herd immunity have we built up in the population to really address some of those questions?
So are you saying we really need 20 years and not 16, and we have to wait?
So our 18-year visit is wrapping up and our 20-year visit so the date, I think that's my biggest point that I want to make. You don't have to wait. I think starting to learn and discuss and think is now, because we will read out, and we collectively as an entire consortia looking at single dose, the evidence around single dose, it will, be reading out in 2025, 4, 5, 6, 7, 8. We have so much data planned to read out over the coming years that I think, starting the consumption and the understanding and review of the evidence it's time.
I wish our biggest problem was that we were putting too many shots in people's arms, that they were getting second or third doses and they only really needed one. That would be a great problem to have. So I think we have to keep that all in mind with the fact that with the data that was presented that we're going down. Our vaccine rates are even, are starting to go down. So, I wonder whether the time to push for single dose vaccine is when we hit better, hit our targets, rather than waiting, rather than changing it. I don't know that people are going to say, oh, well, I'm going to be more likely to do the first dose if it's only one rather than if it's one of three, but I don't know.
But the metrics change. I mean, if like what was put up today is the completion of the series, and that will always be, unless you have 100% getting both doses, that will by definition mathematically be less. So I think even thinking like starting the first dose versus completion of the series. And there's been modeling work to show that where is the benefit? If you have a fixed number of resources, human people, should they be focusing on getting the second dose or even the third dose into people, or should they be putting their work, their efforts into finding the people who haven't been vaccinated? I think we're all coming around that there will be more yield off finding the unvaccinated people and getting a single dose.
And you know what? Single dose matters in this country. It really does. We in the public health sector spend a ton of time and effort and treasure trying to get folks to come up for subsequent doses. If you use age-appropriate single dose HPV vaccination among girls in Pima County, pre-pandemic, we had exceeded 80%. For single dose. If it was the 2 and 3 dose, we were not hitting it. And I think that it is about the way that we use public health resources in order to bring benefit to the community. So I think single dose matters a lot in our communities.
Questions.
Hi, thank you to the presenters. My question, we have 2 questions on our table, but my question is for Dr. Garcia, and thank you for your presentation. I would like to know from your career, what tips do you have on how to address and impact cervical cancer screening rates in the populations that you serve, especially the ones that lived in the border? And then Camille has her other question.
So it's, context matters. Context matters. And the way that we deliver services cannot be divorced from the context that people live their lives. The truth is that in many communities, not just border communities, poverty and housing and education are huge determinants of that person's mortality. It gets back to Phil's sort of commentary. There are so many other things that these exact same populations need. So I think that the key for me is always sort of being cognizant of that context and understanding how we can best insert ourselves into that conversation.
I have the follow-up question, not really related, but that my colleague amplified. So to your point, Dr. Garcia, there was a recent study in JAMA that showed that racial concordance of providers has expanded life expectancy, and we've seen that specifically with racial concordance. So to your point that you just made, and to our colleague that spoke about studies outside of the country, looking at Costa Rica and South Africa, and India, where unfortunately, we have to go to these particular countries to do studies, which can sometimes, in my mind, read, as potentially problematic, as we have a long history of how studies have been done outside of the country. I can think of Puerto Rico and birth control, and so just have to be careful when we're doing studies on underserved people outside of the United States. And that's just my own lived experience, how I'm hearing the studies when I hear about them. So just want to think about that as we think, as we're continuing on the equity discussion that I heard earlier. So thank you.
Yeah, that's a really important point. I would like to, so the studies in Kenya, Tanzania, South Africa, India are not, we're not leading those, our colleagues are, and all of them have local principal investigators that co-lead each of those trials, as do I in Costa Rica, that really strive to have equitable collaborations when it comes to doing research outside of the United States. And it's a topic I'm really passionate about, and I'm happy to talk more about kind of why we put them in these different countries, matching the need and the burden and then, local context and all of it. It's a great point. It's something everyone needs to have their eye on, and I'm always honored to speak about that.
And I would say that domestically, the truth is that our healthcare workforce is not that diverse, and we have a lot of work to get to. It's ironic, by the way. So if you look at any particular demographic of physicians of color, it's by and large, for American Indian, for Latino, for African American, gross disproportionate underrepresentation. I think that that's also part of the issue. I also think that that's also part of the reason why we need community health workers and navigators, because in those professions, in those roles, we're actually very well and perhaps overrepresented. And I think that those are really important interlocutors into the healthcare process. And we need to come up with better ways of bringing them into the system to be able to reach the right population. So I think we need to do all of it.